Before I start, I'd like to thank Volume Attractions and Braco for the kind invitation. I started using this as a resident in the early days when this was a research project in the university. And I've seen this technology mature and developed. I don't think at the end of the day it is something that replaces technical experience that you learn in the OR, but it can supplement. And this is one of the areas we've been actively pursuing with regards to resident training, which I think is an alternative. And I'll demonstrate with an illustrative case. Well, just from the uninitiated, we are Singapore, 5 degrees north of the equator. The little red dot that you see, you can't really make out the geographical area, which gives you an idea of how large we are. The NNI is a national unit for neurosurgery and neurosciences. With 13 neurosurgeons, just had another one joining us. And we do a total of 2,200 cases a year in the institute. I want to present an interesting case of a 46-year-old gentleman who presented with 6 months history of headaches and imbalance of gait, as well as facial numbness. Clinically, he had left cerebellar signs, left sensory neurodeafness, diminished sensation of V2, V3, although the facial nerve function was intact. And this is what you would normally be looking at from a standard MR, multiplanar axial, which shows a fairly large petroclival meningioma compressing on the brainstem involving cavernous sinus. And obviously from a technical approach, a skull-based perspective, one of the things we like to take as an exercise for our residents is to consider what's an optimal approach. Well, as you all know, there are a number of techniques, orbital-zygomatic approach. The petrosal approach is, of course, well described by Osama Mefti, and the retrosigmoid approach with the drilling of the suprameatal bone, and sometimes even low anterior foramen magnum lesion, a far lateral approach. And I think that those are surgical considerations. And we thought that the things we demonstrate today is the 3 following approaches from a skull-based perspective, and try to get the residents to see which would be necessarily an optimal approach from the perspective of an individualized case that we have. With that, move on to the Dextro beam. You can scroll up and down just looking at anatomy, and this is really trying to sync 2D images that we normally see to what we can and what we're going to translate that mental picture into the operating room. But what we thought this system was useful from the uninitiated would certainly be with virtual reality and 3D visualization, help to crystallize and conceptualize not only abnormalities in function and anatomy, but really looking at the structural distortion that this tumor in this particular case. So you can see again the structural lesion in 3D. You can put them in and do a number of combinations. And in this situation, it's just 2D and MR and 3D tumor. You could then, of course, in this particular instance, vascular structure and distortion is critically important if you're going to end up with a reasonable result with surgery. You need to know where your vasculature is going to be. And you could turn it around, and as you can see, this is the carotid artery for which the tumor sort of involves the petrous part. And this part is never going to be removed. That area around the cavernous carotid, again, is where the tumor involves a cavernous sinus. But of great interest would be the basilar artery from a practical perspective, because you want to know where the basilar artery is. And of course, from an initiated neurosurgeon, skull-based with great experience, you can pick up that information that you want from 2D. That may not be very apparent for the surgical resident. And in this situation, we can see that the basilar is really shifted away, and it also involves a vertebral basilar junction. So this will be of critical practical importance when you're planning the operation. The other situation of great importance, of course, is the perspective of the lesion with regards to the skull base. If you're going to do a petrosal approach and you're going to do a mastoidectomy, it'll be useful to know how pneumatized the mastoid is. And in this situation, as you bring it down, you can see the otic capsule, and you can surmise that this will be the area of the bone you're going to drill from a petrosal approach. And what I'm going to do, and of course you can put in the venous sinus, because if you're going via a standard skull-based approach, the venous sinus will be critical. You want to know whether there's a high-lying jugular bulb. If you're going to go via a translab approach, you want to look at the sizes. Of course, again, you can tell from a two-dimensional image if you're an experienced neurosurgeon, but it may not be readily apparent from a surgical resident who may be seeing it for the first time. And of course, you can put the patient in the desired position. In this situation, we like to operate on them in the park bench. And so I'll just move on in the interest of time to do the surgical drilling. And before that, just activate that specific area. I'm just trying to get out the CT and then zoom this image up a little bit so that we could see a little bit better. And from a drill perspective, you now can select the drill size. In the interest of time, I'm just going to simulate it. It's not really going to be but of course your resident can take his time and do so I start off with a retrosigmoid approach, and of course in a retrosigmoid approach, you just want to sort of take away the bone laterally, expose the transverse sinus to the confluence of the sigmoid sinus. And of course, that description of the extended retrosigmoid approach, where you literally skeletonize the sigmoid sinus, may be useful in extending exposure. And so that's the exposure you get from a retrosigmoid approach. You can move in now and have a look and say, look here, is this approach that's useful? Well, you can put in the cortex and all that, but a lot of times with cerebral CSF decanting, in the large tumor, you can actually see quite a fair bit from a retrosigmoid approach. So we were able to sort of emphasize that from a perspective for the resident. And what about trying to do a far lateral approach? Again, you can do a far lateral approach. You can see the condyle just out of here. And of course, because the tumor is very low, we may want to know whether a far lateral approach would be useful in this situation. It may be useful because as you move in now, you can see the close relationship with it and the vertebral artery. And if you want to dissect it, that may be an alternative you can do. And then finally, you can do a standard pechosal approach, taking it all the way down, taking the bone off the asterion, right, do a middle cranial fossa, a craniotomy, remove all the mastoid, and as you can see, when you are moving down, and you literally would be, resident will now be able to appreciate the amount of bone you have to drill, taking all the way the mastoid until you see solid cortical bone. And again, you can select the sinus. In this situation, we want to say, look here, it's not a dominant sinus. You can't even attempt to take it all out. And that's really the approach that you can go for. And I think that would certainly help us to decide, certainly from a surgical perspective, whether this is all going to be possible. And finally, removing the tumor. Again, when you're removing the tumor, what is useful is appreciating the anatomical displacement of the vessels, which you are likely to sort of encounter. And from that approach, you can sort of attempt to see whether this is a good approach to remove the tumor. You can sort of move to a slightly different angle, which is what you will see in a microscope from a coaxial beam perspective. Again, taking down the tumor and leaving, obviously, at the end of the day, looking at how much tumor you have there. And that's the amount of tumor that was left behind. As you can appreciate, this is the amount of tumor that was found over the cavernous sinus, which we had to leave behind, but removing mainly the large majority of the tumor that is compressing the brainstem. So this is something that we found very, very useful. And if I could have my last slide. We are now starting to teach virtual reality. So it is more than a surgical planning system. I think that as an academic unit, we need to think about new ways of teaching our residents, and I think that we can harness that technology. And this has really been the result of interacting with our residents and fellows who have asked us to formally conduct requested for a neurosurgical instructional course which we use virtual reality to teach. And from their feedback, they found it is very, very useful. And we are now, this will be the first neurosurgical course that we're conducting next week in Singapore towards that endeavor and that pursuit. I'm sorry if I ran out of time, but thank you very much for your kind attention.
Probably have enough time to take a question for Dr. Holmes before we go to the next case.
Yes.
Well, can we translate all this planning we make before in the surgery room? Is mean that with the help of imaging gauge surgery?
I'm sorry, I didn't get a question.
Can we translate all the plan we have made in this 3D dimensional? Is mean that in the operative room?
Yeah, I think that it really depends on the case. I think that there are a number of situations whereby this kind of surgical planning would be very, very useful. We just submitted a paper on just surgical planning for AVM surgery. And one of the things the conceptual idea, for example, is that, you deal with the dictum is you do arteries before veins. Conceptually, it may be very difficult to be able to plan a surgical approach based on the 2D image. And one of the things we found very, very useful has been that being able to look at and looking at directionality of surgical attack with particular emphasis to the arterial feeders, taking them first and then leaving the veins down has been very, very important. So yes, in a sense that there are a lot of situations whereby a surgical plan is then taken to the OR and executed. Of course, if you've got a standard acoustic neuroma, you don't really need a surgical plan from a neurosurgeon's perspective because you're going to do it in one of the three standard ways. But I think when there's situations where you would be useful for us, and one of the other examples is a glioma with an eloquent cortex, where you want to look at the DTI and functional image, and you can input that in, and that again can allow you to plan that operation. Which it should be a lot more intuitive than what's the standard stealth station. If you are very comfortable with a stealth station, again, it may not impact you significantly, but a lot of our younger colleagues may be able to follow what you do. And I think that is a useful learning perspective from our end, on top of it just being a surgical planning. So it's a dual role and certainly of great value, certainly for us in the academic unit.